So I just want to go over a couple of different EKG issues. These are things that you need to be familiar with in terms of looking at the characteristics of the EKG and then just knowing what disease is associated with it. So you'll find a number of images, and underneath the image, it will tell you the problem with EKG and the disease associated with it. So here we can see an EKG where we have a P wave, QRST, P wave, QRST, QRS, and then T. A P wave, no QRS complex or T wave, and then it will start up again, P wave, QRST. It's called a second-degree heart block, and this is when the ventricular beat completely disappears. So this is showing that an impulse is actually failing to reach the actual ventricles. So this is usually due to any sort of scarring within the muscle tissue. The next EKG shows a P wave QRST, P wave QRS. And as you can see here, we have the T wave starting to end, but then all of a sudden the P wave shows up. So we basically have a premature atrial contraction. The P wave is too early. So the P wave of the third beat occurs earlier than expected. There's an abnormal shape to it. And this is because you had kind of a random impulse arise in the SA node. Next EKG is atrial fibrillation. There are no P waves existing within this heartbeat. So the heartbeat is irregular and the ventricles are contracting, but the SA node is not functioning at all. So all we can see are QRST situations. There's no P waves present in this particular heartbeat. Obviously, this would indicate SA node is not functioning. The next EKG is a PVC, which is a premature ventricular contraction. The characteristic of this is a very wide QRS complex and usually an inversion of a T wave. So here we can see we have a P wave QRST, P wave QRST. So up to this point, things are relatively okay. And all of a sudden we have this large, wide QRS complex with a inverted T. Okay, so this is just a premature, out of the blue ventricular contraction. And then it goes back to normal P wave QRST. Next one is a lack of oxygen to the heart. The T wave is actually upside down. And this is just showing that we basically have a precursor to a heart attack. Okay, so the inversion of a T wave is characteristic of that. So right here, we can see the inversion of that T wave. Next one is depolarization of tissue that is blocked completely. So it's called a myocardial infarction, which is a heart attack. This is where electrical currents have to go in different directions. So we have a very shallow Q, deep R, and a grossly elevated T with reference to the QRS complex. So here we have P, Q, R, T. P, Q, R, T, P, Q, R, T. Next one is a first-degree heart block. We have a prolonged PR interval. So this is just showing that there's some abnormalities within the SA node contraction or signal to the ventricles. So we have the P wave functioning properly, long delay QRST. P wave, long delay QRST. So something's happening there with that delay. Complete heart block, we basically had random occurrences of waves. There's no communication at all between the SA and AV node. We have a P wave, nothing. QRST, P wave, nothing. P wave, nothing. Random QRS, a T wave that isn't quite done and a P wave shows up. So it's just completely random in terms of what waves are occurring when. So these are diagrams you need to be familiar with and be able to label. A couple of things I just forgot to mention early on in the presentation was just some terminology in around blood pressure. Blood pressure is a measure of the force blood exerts on the wall of arteries. The force originates at the left ventricle. So the left ventricle will contract, exert force on blood, and that blood, because of the force that was placed on it, will hit the wall of an artery. So blood pressure is the measure of that kind of hit. There are two numbers, systolic and diastolic. Systolic is the measure of the pressure or the force when the ventricle is contracting. And diastolic is the measure of the force when the heart is not contracting. So if you think of blood pressure values, 100 over 80, 120 over 100. So the top number is systolic and the bottom number is diastolic. Okay, so the top number is going to be high. That's measure of when the heart is contracting. And then the bottom number is the measure of the force in blood, or the force that blood exerts on arteries when the heart is relaxed. A couple things can change pressure: the diameter of the artery. So we have things called vasoconstriction and vasodilation. Vasoconstriction is when a blood vessel gets smaller and smaller and smaller. This causes blood pressure to rise. And we have another phenomenon, vasodilation, which is when a blood vessel will get larger in diameter, and this causes blood pressure to go down. So think of it as placing your thumb over a garden hose. Turn the water on, that would be blood flowing. If you take your thumb and you place it over a garden hose end, the opening becomes smaller, and as a result, the water is more pressurized. If you take your thumb away from the opening, the diameter becomes greater and the water just goes back to trickling out. The body is constantly going through vasodilation, vasoconstriction based off of chemicals inside of it. So caffeine is a stimulant. Stimulants vasoconstrict, so it's going to cause blood pressure to rise. Alcohol is a vasodilator, causes blood vessels to dilate. Nicotine is a vasoconstrictor because it's a stimulant. Temperatures, when it gets super hot outside, you'll actually vasodilate to force more blood to the surface of your skin so it can cool. This is why you get red in the face, because the vessels in your face are actually getting bigger, allowing more blood to travel there and causing a color change. Vasoconstriction, if you're really cold, you'll notice that you'll start to lose coloration in your skin, especially your extremities. And that's because blood is being shuttled away from your appendages and more towards your heart and your lungs and your brain, to try to maintain the functioning of those parts of your body and keep temperature relatively high.